after desepithelialization to remove some remnants of epithelium. And you're able to make perpendicular rotation completely, and so the risk is to bevel a bit the graft in this area, and that's why it's always better to make the apical incision after desepithelialization to remove some remnants of epithelium. And you continue from mesial to distal until you reach the vertical distal releasing incision. There is no bleeding. There is no bleeding ever, because you don't make any apical incision. There is only the coronal incision. You are very, very superficial, so you cannot bleed at all. So the patient is absolutely calm during the procedure. While when you are making a double layer and you go much deeper to take the second layer, it starts to bleed. And so you have to suction more. And so it's much more stressful also for the patient. Now you remove it. And after removal, it starts a bit to bleed. But it's time you have already finished. Once you remove, the procedure is finished. You only have to make a mattress suture apical to the area to fix some substitute of collagen. The substitute of collagen is applied. You make this mattress suture starting from distal to mesial. It's very important always to start from distal to mesial. You go around the buccal surface of the adjacent tooth, turn around it, go back palatal, and close the knot distal. It's very important to close the knot distal because it's from distal that comes the blood. And so where you place your ligatures, it's much more probable that you block any possible bleeding coming from distal. Normally, one suture has to be done for each tooth included in the graft design. So if you include 3 or 4 teeth, you have to make 3 different suturing. Now the patient is resting. So in your operative field, with your magnification, with your height, with your light perpendicular to the graft, you can distinguish very well the connective tissue from the glandular tissue, from the fatty tissue, from the difference in color and texture. Then you turn your graft and start with the desepithelialization. The desepithelialization is made with one very new cutting-edge 15C blade, and in one shot you have to remove the layer of the epithelium. Some remnants always remain in the most coronal aspect that has to be removed in a further cut. Then you turn your graft and start with the desepithelialization of the other half. Don't forget, once everything has been completely desepithelialized and you see the difference in light reflection and in the smooth or roughness of the surface, to make also the perpendicular incision in the most coronal aspect. You see the color exactly the same from mesial to distal. There is no other tissue different from connective tissue only. Now there is some remnants in the most coronal aspect that I'm showing you tomorrow, that I'm showing you now, that has to be prepared with a perpendicular incision that removes some remnants of the epithelium in the most coronal aspect with this sharp incision perpendicular to the underlying table. It's always better to use this rough surface to apply your graft so it remains firm during the desepithelialization process. And now you really achieve the best quality of connective tissue, always the same thickness from mesial to distal. And this is the only way to get the same quality of the connective tissue from the mesial to the molar area with minimum bleeding and minimum pain for our patient. So you see that thanks to this quality, you can really give your connective tissue graft the same shape you need. And sometimes to give a V shape, it's very important because it means that your connective tissue will be adapted to a very buccally dislocated root, and at the same time will be covering the anatomic desepithelialized papilla to receive blood supply. To triplicate or to duplicate the thickness of this connective tissue sometimes is very important when you want, for example, to fill the dentulous area and make soft tissue augmentation procedure. So the only type of connective tissue that allows you really to give whatever shape you need, whatever thick duplicate, triplicate you need, is the connective tissue coming from the desepithelialization of a free gingival graft. So yesterday we saw how to harvest the connective tissue graft from the palate and the advantages of the desepithelized free gingival graft compared to the harvesting procedure that create a double layer, namely a primary flap, removal of the connective tissue graft, and closure by first intention wound healing in terms of quality of the connective tissue to be harvested. Now it's time to look at the surgical technique, which is called coronary advanced flap plus desepithelized connective tissue graft, which, as I told you yesterday, it's a different story with respect to the bilaminar procedure, because in the bilaminar procedure, the connective tissue graft was used to cover the root, and the coronary advanced flap was used to give blood supply to the graft in order to survive, in order to improve graft survival above the root. And so the final outcome was the graft. And the graft, in terms of color, in terms of texture, in terms of surface characteristics, is always different, or very different. Most of the time it's very different from the adjacent soft tissue. In this case, root coverage is achieved with the coronary advanced flap. But since there is something wrong with the coronary advanced flap by itself, or something wrong at the level of the root surface, we cannot rely on the coronary advanced flap by itself. And so we use the connective tissue graft not to cover the root, but to give stability to the coronary advanced flap. And which are the clinical situations in which we need to add a connective tissue graft to the coronary advanced flap in order to give stability? This situation is when the amount of keratinized tissue remaining apical to the gingival recession is not adequate enough for the coronary advanced flap. Adequate means that we don't have enough height. We said yesterday at least 2 millimeters, and enough thickness. We said yesterday about 1 millimeter thick of keratinized tissue remaining apical to the gingival recession. Another situation that needs the connective tissue graft to be adjunct to the coronary advanced flap is when there is something at the level of the soft tissue margin that impair the stability of the coronary advanced flap, like the insertion of a very close frenulum to the keratinized tissue margin. And we will see in the surgical procedure that you don't have ever to remove the frenulum from the external side, because this creates a scar. And a scar is a tissue that does not give blood supply, and so you further risk to lose the small amount of keratinized tissue remaining, together with creating a scar in terms of aesthetics, which is not nice for our patients. Another situation in which you need to add the connective tissue graft is where the patient biotype is that one that the mucogingival line is not so apically displaced. Remember yesterday we said that the increase in the keratinized tissue height depends on the realignment of the mucogingival line. And so if you have a patient with very, very high position of the mucogingival line, you can predict a good increase in the keratinized tissue height, while in the patient in which the keratinized tissue also at the adjacent teeth is very, very shallow, you cannot pretend to increase too much the keratinized tissue height. And so you have to help the patient maintenance in the postoperative phase by increasing the soft tissue thickness by adding a connective tissue graft to the coronary advanced flap surgical procedure. The other two situations, depending on the root surface, which require the adjunct of the connective tissue graft, are two opposite situations, namely when you have a very deep root abrasion. We said yesterday that when you have a very deep root abrasion, there is still the risk for soft tissue collapse in this concave area that has to be sustained by the use of a connective tissue graft. And the opposite situation is that one in which the root is very prominent. When you have a very prominent root, the space between the soft tissue of the coronally advanced flap and the prominent root is very, very small, and so you cannot pretend to form too much thick blood clot, and so the increase in the soft tissue thickness you can achieve with the coronally advanced flap by itself is never enough. And so you have to use something that is more stable, like the connective tissue graft, to increase the thickness of the soft tissue and achieve long-term outcome, which depends on the thickness of the soft tissue more than on the height of the keratinized tissue. So in this clinical situation, you see you have very, very shallow amount of keratinized tissue remaining. We can say that less than 1 millimeter. This is completely probable, and where does the probing pocket depth? Hence, immediately there is the insertion of the frenulum. In this clinical condition, it's very important that you understand that the stability of the flap does not depend anymore on the presence of keratinized tissue margin. In other terms, when we were using the coronally advanced flap to cover the root by itself, we said that it's very important to have a good amount, a good thickness of keratinized tissue to be coronally advanced, to be adapted against the convexity of the clinical crown, to give stability to the most coronal aspect of your coronally advanced flap. In this case, you cannot rely on the stability of the keratinized tissue because it's very poor. So you have to look stability at the other area where stability is very, very important, and this is the interproximal area. So once you don't have enough keratinized tissue remaining apical to the gingival recession, you have to prepare your surgical papilla, very large, 3 millimeters wide, in keratinized tissue. Since this papilla will be placed coronally above the anatomic desepithelialized papilla, at the same time also the keratinized tissue margin will be placed in the more coronal position. But it's the stability we can achieve at the level of the interdental area, surgical papilla, keratinized tissue above the anatomic papilla, desepithelialized keratinized tissue. This gives stability to the coronally advanced flap, even if there is no good amount of keratinized tissue remaining apical to the gingival recession. So we move the concept of stability of the flap from the keratinized tissue apical to the gingival recession to the keratinized tissue lateral to the gingival recession. You see, after making anesthesia, that the lining mucosa of the lip is swelling, and so you can now very, very well understand that the vestibulum depth is much reduced than it seems, but also that you have a lot of amount of very, very thick lining mucosa of the lip that has to be free from muscles, superficial and deep, like we see yesterday, in order to make your flap coronally advanced very, very passive. But you see that the only area where you can find keratinized tissue is the interdental area. And so it's at the level of the interdental area that you have to prepare very, very stable surgical papilla in keratinized tissue. So you will prepare 3 millimeters wide, first of all with the design, 3 millimeters wide horizontal incision in keratinized tissue, and then you have to make vertical releasing incision. In this case, unfortunately, you cannot limit the dimension of the vertical releasing incision like we did yesterday in a different patient biotype where we had a greater amount of attached gingiva of the adjacent teeth because since you don't have an attached gingiva of the adjacent teeth, obviously you have to extend more your vertical releasing incision in alveolar mucosa, so you will be obliged to make periosteal anchored suture once you make your suture of the vertical releasing incision of your flap. So obviously, you should try always to limit as much as possible the extension in vertical releasing incision of your in alveolar mucosa of your vertical releasing incision. But in this case, since the alveolar mucosa is so close because you don't have attached gingiva also in the adjacent teeth, you have to extend a bit more, let's say 2 and 3 millimeters, your vertical releasing incision in alveolar mucosa, lining mucosa of the lip. So the only thing that will be stable once this flap will be coronally advanced, is the surgical papillae above the anatomic papillae, because it's keratinized tissue. And that's why I believe that this technique is much superior of every single type of tunnel technique, because in the tunnel technique, you leave the papilla completely firm, and so once you coronally advance your flap, you coronally advance your keratinized tissue, the stability of the keratinized tissue does depend only on the presence of very thick and very big connective tissue graft below, while in this case, the stability of the coronally advanced flap is stable by itself thanks to the anchorage and blood supply of surgical papillae above the anatomic papillae. And the graft is only used to give stability to the coronally advanced flap, prevent shrinkage, prevent collapse. But the amount of connective tissue graft, the thickness of the connective tissue graft you can take from your patient palate, it's much smaller with this technique with respect to every single type of tunnel technique. And the other advantage is that in the tunnel technique, you have exposure of the graft, while in the coronally advanced flap plus connective tissue graft, the graft is never exposed. And so when you see the healing, you don't see any difference in color, any difference in texture and surface characteristics. You can see that the frenulum is coming back in the original position, but now you have a good amount of keratinized tissue, good soft tissue thickness, good aesthetic outcome to cover the gingival recession. So now, exactly what we said yesterday, we have to start with preparing a very well done split thickness surgical papillae in keratinized tissue, trying to preserve as much as possible the epithelial and connective tissue thickness all along the 3 millimeters extended surgical papilla until you reach an imaginary line connecting the soft tissue margin to the vertical release incision, which is the base of the surgical papilla. Now you have to repeat the same incision at the level of the homologous contralateral surgical papilla. So you get in these lines of incision, and by keeping the tip of the blade parallel to the soft tissue margin, you have to give the surgical papilla the same thickness without the need to get with a knife inside the keratinized tissue margin. Now you take your periosteum elevator and start the full thickness elevation in order to meet the bone crest, and you have also to overcome the bone crest with your periosteum elevator in order to give as much as possible thickness to the small amount of tissue remaining apical to the gingival recession. Now it's time to make the deep incision parallel to the bone in order to detach the whole amount of submucosal tissue from the periosteum layer. And you see that there is enormous thickness of submucosal tissue filling the lining mucosa of the lip that now you have to get rid of in order to make your lining mucosa be able to be coronally advanced with no tension. So once the deep incision has been made, you see that there is no possibility to cover your recession with the flap, because the flap is still too much anchored to the all muscles included in the submucosal tissue. And even if you go further apical in the apical incision, which is not necessary at all, but just to show you from a didactic point of view that even if you go further apical in order to remove muscles from the periosteum, nothing changes in the possibility of your flap to be moved coronal. It's exactly the same situation of before. So this is to show you that it's not the deep incision that makes the difference. The deep incision must be extended the minimum you can in order to make your submucosal tissue detached from the periosteum layer. But what is important in order to make your flap coronally advance in a very passive way is to get rid of your flap, namely alveolar mucosa, from the submucosal tissue. So now it's time to make the very superficial incision. This is the deep incision, which is not useful anymore. And from the deep, you have to go to the superficial. And thanks to this superficial incision, you are removing all submucosal tissue from the inner aspect of the alveolar mucosa. And you have to be very careful. You have to use a very new knife in order to cut as much as regularly as possible the insertion of the submucosal tissue in the lining mucosa of the lip. And so you need to use a wider area of your blade in order to make this cut as much as precise, as much as one shot as possible, without creating too much traumatism or too much tears on the muscles and submucosal tissue. This submucosal tissue that has been isolated, you see that the inner aspect of the alveolar mucosa should be white because it should contain only connective tissue, and now the submucosal tissue that has been separated from the periosteum on one side and from the lining mucosa on the other side will retract apically and will allow you to make your coronally advanced flap made of alveolar mucosa only very, very passive in coronal direction. You can see that now you can pull this, you can do, whatever you want with this alveolar mucosa, because the alveolar mucosa, it's a very elastic fibers, and so you can pull it. And you see that there is no more any frenulum. You remember that there was a frenulum at the marginal? Now there is no more frenulum, because once you remove the muscles, the frenulum doesn't exist anymore because it's no more active. And so you can perform your surgery in the alveolar mucosa as it was not present any frenulum inserting in the soft tissue margin. It's completely, completely passive. And if you want to see what is the thickness of the alveolar mucosa all over the world, you can place your blade below it, and you can see that by transparency, this is the submucosal tissue that remains apical because it's been separated. This is the thickness of the alveolar mucosa. You know, and will be very important when we will face multiple type of gingival recession, that this is the thickness of the alveolar mucosa containing both epithelium and connective tissue. So once we don't have any vertical release incision, we have to check the movement of our blade by transparency through the very thin lining mucosa and see the movement of the blade below the soft tissue, leaving a soft tissue that is no more thick than this. If you have a thicker tissue, it's not connective tissue, but it's fatty, glandular, and muscles that you leave in the inner aspect of your alveolar mucosa. Now you take a gauze, you start to protect your flap in apical direction, you measure how much of the root has to be grinded during root planing procedure, and you start with root planing. If there is an area apical to the probing pocket depth that is not probable before the surgery, it means that you don't have to make root planing up to the bone crest, but this small area of about 1 millimeter apical to the probing pocket depth is called anatomic bone dehiscence. Still have some connective tissue fibers attached, new cementum, and you don't have to make any root planing on this area. Once you achieve a very hard, smooth, and clean root surface, it's time to apply ADTA gel. ADTA gel is applied for 2 minutes, 24%, in order to remove the smart layer. Now it's very important you understand how you have to make the desepithelialization of the papilla. You see that you can use only the tip of this very micro 15C blade in order to prepare the base of the anatomic papilla only with a cut. So since this is a blade, it's cut. And this is a very new blade, and you can cut at the base and elevate only some of the epithelium at the base of the anatomic papilla. Now that the cutting surface has already been prepared with the knife, you can follow the cutting surface that you have prepared with a knife with a microsurgical scissor. The scissors can follow a surface that already been cut by the blade, but they cannot cut by themselves because they are not so precise in the cutting surface as it is the tip of the blade. So first, the base of the anatomic papilla must be desepithelialized with the use of the blade, and then once the tip of the papilla is reached, you see that the suction is getting very close to the papilla. The suction creates air, and this air creates the condition in which the epithelium that has been already detached by the blade from the connective tissue will be turned in a occlusal direction, so you can see with your magnification very, very well the cutting surface that was prepared by the blade, and you can follow it with the microsurgical scissors until the whole epithelium is removed up to the tip of the papilla, and there is the suction who immediately remove the epithelium that covers the whole apical and coronal extension of the desepithelialized anatomic papilla. This obviously has to be done in both the anatomic desepithelialized papilla in order to create very, very vascular connective tissue beds that are critical in this case for the success of the surgical procedure, because as we said, we don't have keratinized tissue apical, but we have keratinized tissue interdental. Now you have to measure how much connective tissue graft do you need, and we normally apply our connective tissue graft for about 2.5 millimeters on one vascular bed, 2.5 millimeters on the other vascular bed, and then we apply the mean portion of the graft above the root surface. So we will take about 5 millimeter long graft with respect to the width of the gingival recession measured at the level of the cement enamel junction. Considering that the cement enamel junction is a curved line, you always have to go to the palate and elevate a connective tissue graft that is a free gingival graft that is about 1 millimeter more than the width of the gingival recession you can measure with the straight probe. So if you can measure that the straight probe is 1, 2, 3, 4 millimeters, it means that once you consider the curve, you have to consider 5 millimeters plus 5. So you will take in the palate 10 millimeters long of free gingival graft, while the apical coronal dimension that you have taken from the palate is now a fixed data. It's about 4 millimeters. You don't have to take 5, 6, 7, 8, 10, depending on how deep is the root exposure. 4 millimeters as a graft is more than enough to give stability to your corneal advanced flap. Obviously, since you have to practice yourself in the desepithelialization process, since some of this graft has to be reduced in apical coronal direction when you make the perpendicular incision to remove remnants of the epithelium in the most coronal aspect of your incision, when you go to the palate, you will take about 5. Let's say 1 millimeter more what you really need in terms of graft. So you will take 10 millimeter long, 5 millimeter side graft from the palate in order to have about 9.5 millimeter long and 4 millimeter height of connective tissue graft to be harvested. If you take such a small graft, 10 plus 4.5, 5, really with a thickness that is less than 1 millimeter when you take a free gingival graft, the postoperative pain, the postoperative bleeding is absolutely nothing. This is the vascular bed where you have to apply also. It is very important that you are going to apply your free gingival graft desepithelialized above the anatomic desepithelialized papilla, which must, apical to the anatomic desepithelialized papilla, which must be left completely free for the surgical papilla of the coronally advanced flap. You see that when you take such a small graft in apical coronal direction, you can go very, very posterior in your patient palate. We can go at the level of the 7, at the level of the 8, since the apical coronal dimension is very limited, 4 to 5 millimeters, and since you are so superficial in your harvesting procedure, there is no risk of vessels at all. And so you can make your harvesting procedure where the connective tissue is really the best in your patient mouth. You know, as much as you go distal, the connective tissue improved. But if you consider the tuberosity doesn't exist almost ever as an area of harvesting procedure because you don't have enough mesial distal dimension. Namely, the connective tissue graft should be at least 10 millimeters in the mesial distal dimension. And it's very rare that you find distal to the premolar 10 millimeters long area to be harvested as a tuberosity. Most of the time you have 5, 6, 7, which is not enough because the connective tissue graft should be placed also in the vascular bed. You see that once this thin and small free gingival graft is removed, there is such amount of connective tissue remaining, which is still fibromucosa, that the bleeding is almost nothing, and the pain is completely nothing, because you did not reach with the harvesting procedure the submucosal tissue. Now you can apply some connective tissue substitute to the area just to improve the blood clot stabilization. You make the horizontal mattress suture starting from distal. Then you turn around to the corresponding tooth where the graft is taken, and you cross your suture above the substitute material. And as I told you, you have to close the knot, apical and distal. It's very important to use this kind of material. This is the 6-0 PGA material, and the advantage of this material is that once you fix the position of the knot, even during the time it takes for making the second knot, the knot remains there. Sometimes when you use monofilament or very elastic suture, during the time it takes to prepare the second knot to fix the first one, the first knot is going somewhere else. And so it's much more difficult to fix the knot exactly where you want. And it's very important to fix the knot where you want, because in this case, to fix the knot distal and apical means to block any vessels with a ligature coming from distal and apical, and so the bleeding, once this knot is closed, is completely under control. Now we have 10 millimeter long, as we said. We have about 5 millimeter height. The inner aspect is already ready. You don't see any fatty and glandular tissue because you are so posterior and so superficial that you can remain in the harvesting procedure inside the fibromucosal tissue, and so you can start directly with the desepithelialization. As we said yesterday, desepithelialization is not a peeling, but you have to cut a surface. So first of all, you have to take with your knife a certain amount of surface, and you can see that for this particular job, I don't use the tip of the knife that is used for the desepithelialization, but I use the body of the knife, so you can cut more uniformly in one shot cut without creating too much traumatisms on your wound area. And this is very important, why you need this type of blade that allows you to make a very uniform cut, and in one shot cut you should be able to get rid of all the epithelium from the mesial to the distal aspect of your connective tissue graft. The second incision is the coronal one to remove some remnants, and the third incision you remove is the apical one. About 3 cuts are more than enough to remove completely the epithelium from one side. Then you turn the other half of your free gingival graft and you make the same 1 cut in the middle, 1 cut in the most coronal, and 1 cut in the most apical, so to remove very uniformly the epithelium. Then what you have to do, and not to forget to be done, is this cut perpendicular to your table, because in the most coronal aspect, when you take the free gingival graft from the palate, very frequently you bevel the incision, and so there is some remnants of the epithelium that remain with no enough connective tissue below, and so you remove about 0.5 millimeter, no more, of epithelium, which is not adequately sustained by connective tissue. So when you look at the thickness and the color of the external, of the inner surface of your graft, this is very white, this is very thick, and it perfectly corresponds to the area where you want to increase the soft tissue thickness. Now it's very important to use a very short needle with a resorbable suture, 7-0, 8 millimeter needle, short needle in order to get from the graft to the base of the anatomic papilla in one shot again, because if you have a very long graft, a very long needle, the risk is to get out too much occlusally, too much palatally. And so once you have to close, the risk is to shift your connective tissue graft above the anatomic desepithelialized papilla, while you have to fix your connective tissue graft at the base of the anatomic desepithelialized papilla. So now you take the needle, and it's very important to fix the knot again above the graft. So you fix your knot above the graft. So in this way, the graft will remain exactly at the level of the cement-enamel junction of the tooth without covering the anatomic desepithelialized papilla, which must be left completely free for the surgical papilla of the corneal advanced flap. And you see that thanks to this specific type of suturing, during the time it takes to make the second knot, the first knot remains exactly there, so you are much more precise in fixing your knot where you want to make and in stabilizing the connective tissue graft exactly in the position you want to place. The same thing is done at the distal papilla. Very short needle. Place the knot at the level of the graft. Close the knot exactly in the same position without moving the graft too much corneal. And so you leave the whole anatomic desepithelialized papilla completely free for the corneal advanced flap, namely for the surgical papilla. Again, as we said yesterday, the first suture is the mesial apical, so the most apical along the mesial vertical releasing incision. But now, unfortunately, when you have to suture the alveolar mucosa, we don't have attached gingiva on the adjacent tooth, so we have to change suture material. We have to use the 11 millimeter long, not the 7 millimeter long, but the 11 millimeter long needle, and we have to get the periosteum in order to anchor our alveolar mucosa to the alveolar mucosa of the adjacent tooth, because we don't have enough attached gingiva. And so this is a periosteal anchorage suture, which is made with the surgical papilla placed in the final position with the pinset, and you go from your flap, you take the periosteum and get out in the alveolar mucosa of the adjacent tooth in order to fix, again with a knot, the most apical extension of the vertical releasing incision in the right position. You don't have to pull this suture, because every single suture will be useful for the next one to stabilize the flap in the more corner position. Until you are in the alveolar mucosa, you have to use this stronger suture anchored to the periosteum, while once you will start the suturing at the level of the attached gingiva of the adjacent teeth, you will change the suture back and you will come back to the short needle 7-0 suture. Now that the base of your flap has been sutured with periosteal anchored suture, it's this time to fix the surgical above the anatomic papilla. And you know that this is a very important suture. It's called a sling suture. It's the same suture we did yesterday for the surgical above the anatomic papilla. So one shot perforation, surgical, anatomic, and palatal papilla. Now you turn your needle, you go buccal with the back of your needle. Again, surgical, anatomic, and palatal papilla. You turn the needle, you go back buccal, and close. And before closing, you have to check that this suture is compressing surgical above the anatomic papilla exactly in the middle. You have to start to see some ischemia of the small amount of keratinized tissue remaining before closing the second surgical and compressing the second surgical papilla above the anatomic papilla. And this suture is the only suture that you really have to tight, that you really have to pull, because you have to block any attempt of blood to escape from the soft tissue margin. Once this suture is finished, you have to see your soft tissue margin, which is well adapted to the convexity of the clinical crown. There is no bleeding seeping out the soft tissue margin, and now your keratinized tissue is perfectly adapted to the convexity of the clinical crown. What you have to complete is the closure along the vertical releasing incision at the level of the attached gingiva of the adjacent teeth, but since you have attached gingiva at the level of the adjacent soft tissue, you can use the very short needle, 7-0 suture. Try not to get with your suture inside the sulcus, in order to achieve primary intention wound healing all along the vertical releasing incision, and close it very, very precisely with this very, very thin but very, very precise type of suture material. Sutures will be removed after 2 weeks. It's very important to remove the suture after 2 weeks concerning the sling suture, the coronal one. The vertical releasing incision should be also removed before, if you want to see your patient even before, because in the vertical releasing incision you have primary intention wound healing, and so you can also remove the suture before than 2 weeks. But in the most coronal aspect, where stability of the blood clot depends on this quality of tight adaptation, surgical above anatomic papillae, surgical above anatomic papillae, and it is the keratinized tissue which is adapted above a vascular root surface. You don't have to remove the suture too early, because too early the blood clot is not stable enough, and there is a risk that during the trauma you can create, during suture removal, you can destroy, you can detach the blood clot from the root surface. So in order to remove the last suture, you always have to wait 2 weeks, in which the stability of the blood clot is much more. And you see that at the end of the surgery, about 30 minutes after the surgical procedure, you check again your patient for the complete absence of bleeding getting out from the soft tissue margin. The small amount of keratinized tissue remaining must be completely adapted to the convexity of the clinical crown. The vestibulum depth must be replaced. And you see that there is no sign of the frenulum. Do you remember that there was a frenulum inserting exactly at the level of the soft tissue margin? This frenulum, which was here, comes back exactly in the same position during the healing, but not more marginally, because now marginally you have the combination of the coronally advanced flap plus connective tissue graft, which gives you both the advantages in terms of aesthetics of the coronally advanced flap, with no difference in color, texture, and surface characteristics, and at the same time you have the increase in the soft tissue thickness that you can appreciate in the profile of the tooth, in which the convexity of the composite restoration is followed by a very convex surface also of the soft tissue, thanks to the combination of the connective tissue graft plus the coronally advanced flap. Despite the coronally advanced flap was so thin, despite the presence of the frenulum, this is completely there, covering the connective tissue graft with good aesthetic outcome. And also in the longer term outcome, there is no difference in color, texture, and surface characteristics. The only thing that you can see is during time the increase in the keratinized tissue height, thanks to the realignment of the mucogingival line, and the further increase in the soft tissue thickness, thanks to the maturation of the connective tissue graft below.